Good morning, good afternoon, good evening, wherever you are. Welcome to another intensivecarehotline.com and intensivecareathome.com live stream. This is your opportunity to ask me anything: life support decisions in ICU, tracheostomy decisions in ICU, and intensive care at home. That's what we're covering today. In particular, we'll be covering today: if ICU doctors are rushing tracheostomy decisions, here's what families in intensive care need to know how to save your loved one's life and making sure your loved one gets best care and treatment always. So again, welcome to today's YouTube Live. My name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. Today's topic is absolutely critical: tracheostomy and ventilator options in ICU, what families must know before it's too late, and what to do if ICU teams want to rush a decision. So before we go into today's topic, what makes me qualified to host such a YouTube Live? Again, my name is Patrick Hutzel. I'm a critical care nurse by having worked in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care here at intensivecarehotline.com since 2013. And we've been consulting and advocating for families in intensive care all over the world. And I can very, very confidently say that we have saved many lives for our clients in intensive care. And you can verify that on our testimonial section at intensivecarehotline.com. And you can also verify it on our podcast section at intensivecarehotline.com, where we have done client interviews. I'm also the founder and managing director at Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home 24/7 as a genuine and legitimate alternative to a long-term stay in ICU, predominantly for long-term ventilated adults and children with tracheostomies, but also for ventilated adults and children on BiPAP, CPAP without a tracheostomy, also for adults and children with a tracheostomy without ventilation, also for home TPN, home IV potassium, home IV magnesium infusions. We are managing central lines, Hickman's lines, PICC lines, as well as ports at home. We are providing PICC and pitch tube management at home, nasogastric tube, nasojejunostomy tube management at home, cough assist management at home, ventilation weaning at home, seizure management at home, and palliative care at home, including ventilation weaning, all of that with 24/7 critical care nurses in the home. We are currently operating with intensive care at home all around Australia, in all major capital cities, as well as in all regional and rural areas. We are serving NDIS clients all around the country. We are serving TAC and WorkSafe clients in Victoria or other states whenever there are TAC clients. We're also serving the veterans, the DVA population, and we are offering services to hospitals, private health insurances, and private patients as well, of course. Now, I also want to welcome any viewers that watch this on replay, because I know there's always a lot of views on replay. And if you like these videos, then please give it a thumbs up, share this video with your friends and families, whoever has a family member in intensive care or needs intensive care at home. Also, Subscribe to my YouTube channel if you want to get regular updates here for families in intensive care and intensive care at home. So without further ado, let's talk about today's topic. That if your loved one is in intensive care and doctors are talking about tracheostomy, ventilator, or long-term ventilation in particular, you need to stay on for this live show today. I'll explain everything you must know to make the right decision for your loved one. Type live into the chat if you're joining me live, and replay if you're watching later. And don't forget to subscribe, hit the notification bell, click the like button so you don't miss any of my upcoming ICU live streams. So, for those who are new here, like I said, I'm a critical care nurse consultant with over 20 years of ICU experience, having worked in intensive care units in Australia, the UK, and Germany. I help families like yours making informed decisions when their loved one is in intensive care, so you can have peace of mind, control, power, influence, get real answers, not feel powerless in front of doctors, ICU nurses, and hospitals, so that you make sure your loved one always gets best care and treatment. And how would you know if your loved one gets best care and treatment? When do you know that? By asking the right questions. The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's exactly what you're here for, to learn all of that. And you can also get one-on-one consulting at intensivecarehotline.com, where we can be available 24/7. So let's look at ICU and tracheostomy and what families aren't told. So let's look at what is a tracheostomy and why ICU might suggest it. The real reason ICUs want tracheostomies done early, for example, bed management, not always patient-centered. Typical timelines when a patient fails extubation or cannot wean from the ventilator. The critical window of opportunity families have before decisions are made without their input, but also the critical window of opportunity that ICU teams have to extubate safely and avoid the tracheostomy. We look at the hidden dangers of premature tracheostomies and premature discharge to, in the US, LTACs, rehab, or also the hospital ward or hospital floor. We look at the distinct differences between countries, especially US, Australia, UK. And we'll dive into all of that. If you have any questions in the meantime, type them into the chat pad or contact with me live on the StreamYard link here. Now, let's dive deeper into this. Families in intensive care often think a tracheostomy means their loved one is getting better. But in reality, it's a sign the ICU wants to free up a bed in some circumstances. That's why you need to understand the timing, the risks, and the alternatives. Remember, you have a say. ICU will rarely tell you this, but a tracheostomy is not always the only or the best option. Now, I also need to highlight here, I am not opposed to a tracheostomy. A tracheostomy has its time and its place for the right patient, the right time, for the right situation. But you need to be able to understand when is the right time and when is the right timing, right? It's not always that ICU wants to free up a bed, but it can be that they want to free up a bed. So, number one, you need to get access to the medical records, full stop. And I might have said it before, and I probably will say it a few more times during this video. You will need to get access to the medical records, right? I cannot understand why. I can't believe how many families in intensive care contact us that do not have access to their loved ones' medical records. Why is it important? Well, I'm glad you've asked. When we talk to families in intensive care, obviously they're giving us a field report, so to speak. They're telling us about what's happening with their loved one in ICU, and they're replaying the story that they get told by the intensive care team. Now, when you then look at the medical records, we might see a completely different story, right? I'll give you an example. So let's just say ICU says, oh, your loved one won't be able to come off the ventilator. They need a tracheostomy. Or they might say your loved one can't be weaned off the ventilator. The best option forward is to withdraw treatment and provide palliative care and let your loved one die because it's quote unquote in their best interest. When we then look at medical records, we have found in many cases that patients are stable, in many cases even that they're on minimal ventilation support, and yet ICU teams are trying to quote unquote sell them on a withdrawal of treatment or a withdrawal of life support, which is simply cruel. Right? It's not ethical, it's not moral, but I can tell you that after over 25 years of critical care nursing, I've seen the good, the bad, and the ugly. And you better learn from someone that's seen the good, the bad, and the ugly than making mistakes yourself, because you are in a once in a lifetime situation that you simply cannot afford to get wrong. So let's look at strategies and how you stay in control. So there's usually three options usually given by ICU teams to families. Number one is extubate, and that should be your ideal scenario. So extubation means the permanent removal of the breathing tube, right? Just as much as intubation is the insertion of a breathing tube, right? So what have I been saying for a long time here? The minute your loved one is in ICU and is on a ventilator with a breathing tube, your questions should ideally straight away go to what is the ICU team doing to get your loved one off the breathing tube and the ventilator. That should be one of your first questions, right? And the next question is, what is the ICU doing to prevent your loved one having a tracheostomy or needing a tracheostomy? And I should probably go even further than this. You need to say, what are you doing to get my loved one off the ventilator and the breathing tube without the shadow of a doubt? Without the shadow of a doubt. And also, what are they doing to avoid the tracheostomy? Again, without the shadow of a doubt. Right? How can you find out? Well, I'm glad you've asked. Well, I've made a video a couple of years ago where I talk about how to wean a critically ill patient off the ventilator and the breathing tube. That I highly recommend you watch. Type that in the chat pad on our website at intensivecarehotline.com. How to wean a critically ill patient off the ventilator and the breathing tube. There would be another video, how to avoid a tracheostomy. Right? I highly encourage you to watch those videos and or read the blog post. Right? Why is this important? Well, it's important for a number of reasons, but first of all, you want to minimize the time your loved one spends on life support. Mechanical ventilation is life support, right? You want to minimize that time spent. That's the main reason. Another very important reason is, when someone is intubated and on a ventilator with a breathing tube, they are often in an induced coma, i.e. they need sedatives such as propofol, midazolam/Versed, Precedex, opiates such as morphine, fentanyl. Especially the midazolam and the opiates are highly addictive in nature. They come with numerous side effects, right? Therefore, you want to minimize the time spent, the risk of complications such as neurological events, strokes, but also deconditioning, such as, muscle wastage every minute your loved one is spending in an induced coma is also real, right? Other issues and complications that could come out of mechanical ventilation and the breathing tube is simply muscle wastage. deconditioning, right? The longer your loved one stays in an induced coma, the higher chances are, or the higher the risk, they can't be weaned off the ventilator, right? If they can't be weaned off the ventilator, there's usually a much higher risk for a pneumonia, for a ventilator-associated pneumonia, right? So let's wave a magic wand for one moment. Stop sedation, stop opiates. Your loved one wakes up, there's no brain injury. They are obeying commands, they're squeezing your hand, they're opening their eyes, they're trying to talk, they're even trying to take out the breathing tube themselves. Their arterial blood gases are good, their chest x-rays are good, they've passed the spontaneous breathing trials, their blood gases are good, PO2 and PCO2 and pH are within normal limits. They're not awaiting surgery. Right, let's extubate. That's the ideal scenario. And timelines for that can vary depending on why your loved one is in intensive care. Those timelines can vary from less than 24 hours, sometimes after open heart surgery, to days and weeks, right? Ideally 2 weeks at the maximum, because, the literature and research suggests that by day 10 to 14, approximately, a tracheostomy should be done. That leads me to the next option the ICU team is giving you, which is the tracheostomy. Once again, before you even talk about a tracheostomy with the ICU team, your question should be, number one, what is the ICU team doing beyond the shadow of a doubt to get your loved one off the ventilator and the breathing tube? That's number one. What is the ICU team doing beyond the shadow of a doubt to get your loved one, or to avoid a tracheostomy, full stop, and get your loved one extubated and back to recovery as quickly as possible, back to a quote-unquote normal recovery as quickly as possible? All right. So before, again, you talk about a tracheostomy, maybe let's ask the ICU team, what if they extubate and it fails? What are the options? Well, the options are to re-intubate, but another option might be to put your loved one on BiPAP or CPAP ventilation with a mask to buy them some time to see whether they can breathe without the breathing tube, right? So you need to understand the intricacies of intensive care, right, to know what's next, what can be done in case extubation fails. Also, high-flow nasal bronchs might be another option, high-flow nasal bronchs with an airvo. So let's say all of that fails, then a tracheostomy might be the only option. Excuse me. But also, what's also extremely important is, and what's also underestimated, once again, in order to ideally remove sedation, stop opiates, wake up your loved one, pass them, get them to pass spontaneous breathing trials, right? They need to be awake, alert, obey commands, all of that. So then, with the tracheostomy, day 10 to day 14 of the inability to wean off the ventilator and the breathing tube, that is if the ICU team has done everything beyond the shadow of a doubt. And again, I asked you to refer back to my article, How to Wean a Critically Ill Patient Off the Ventilator and the Breathing Tube. If you can rule out that they've done everything beyond the shadow of a doubt, including mobilization, getting out of bed, physiotherapy, physical therapy, moving, breathing exercises. If all of that failed, then it's probably reasonable to talk about a tracheostomy, right? So, what is a tracheostomy? A tracheostomy is basically a breathing tube that goes into the neck, and the breathing tube is taken out of the mouth. It's basically an exchange of breathing tubes. However, tracheostomy is so much easier to tolerate, right? In the best, again, I can't stress enough that the best case scenario is always to remove the breathing tube so that your loved one can breathe spontaneously, right? With a tracheostomy, it's easier to tolerate. Sedation and opiates can be stopped. It's easier to do spontaneous breathing trials. It's easier to move towards talking, swallowing, as opposed to leaving the breathing tube in indefinitely, which is not really an option. It can damage the throat, it can damage vocal cords, right? So it's not really an option long term. The breathing tube is not an option long term. But even if your loved one does need a tracheostomy, right, you then need to ask what are the next steps to wean your loved one off the ventilator and the tracheostomy. You know, that is also an incredibly important question to ask. Right? The goal still should be to wean your loved one off the ventilator and the tracheostomy. The goal should always be weaning. Now, there are exceptions to the rule where someone can't be weaned indefinitely, right? Such as C1, C2 spinal injuries, MND, motor neuron disease, and so forth. What you should be asking whether your loved one is ventilated with a breathing tube or a tracheostomy, you should always ask, how are they moving towards spontaneous breathing trials and weaning assessments? What are their plans to wean your loved one off the ventilator? Always a question for you to ask. So, we also want to look at how to question the need for a tracheostomy safely and effectively. We want to look at the risks and benefits of a tracheostomy, right? What are the risks and benefits of a tracheostomy? You know, well, one of the risks is it's a surgical procedure. Bleeding can occur, right? Bleeding can occur, right? A pneumothorax can occur. Surgical emphysema can occur, right? So, now, this is where so many families in intensive care are also pressured. So, this is where families are being pressured, right, for all the wrong reasons by ICU teams, often without full information. And that's why I want to show you exactly how to question the need for a tracheostomy safely and effectively and understand the real risks and benefits. So step one, understand why the ICU suggests a tracheostomy. Usually ICU doctors will recommend a tracheostomy after about 10 to 14 days of mechanical ventilation and intubation and a breathing tube, meaning your loved one has been on a breathing tube through the mouth for that long. The main reasons they'll give you are it's more comfortable for the patient than the tube in the mouth. It's easier to wean from the ventilator. It allows for long-term ventilation if needed. All of that can be true, but it's not the full story. What they won't tell you is that ICUs often push for tracheostomy because they want to free up an ICU bed, especially if you are in the United States. So in the United States, a lot of ICUs are pushing for an early tracheostomy and a PEG tube so that they can send their loved ones to an LTAC. LTAC stands for long-term acute care, or long-term acute care hospital, and we strictly advise against that. So a tracheostomy, once again, has its time and in place, but it doesn't have its time and in place if it's used as a vehicle and a conduit to send your loved one to an LTAC. In other countries, such as in Australia or in the UK, tracheostomy, if anything, occupies an ICU bed for much longer. So it's actually not a bad thing in those countries. You have to read between the lines, and that's why you need insights from us here at intensivecarehotline.com. We can distinguish between what's good, what's bad, what's in your loved one's best interest. So it is a case-by-case basis. Once a tracheostomy is done, the patient can be moved out of ICU in the US in particular to a long-term care rehab or LTAC facility, even if they're not ready. That's when most families lose control if they haven't lost control before. In other countries such as Australia or the UK, tracheostomy often means that patients will be in ICU long-term, which is also not a good thing. So, what are the questions you must ask before signing for a tracheostomy or giving consent for it? So before you give consent for a tracheostomy, you want to ask these specific questions. Write them down. Number one, what are the exact reasons you're recommending a tracheostomy right now? Has my loved one had one or multiple spontaneous breathing trials, and did they pass them? Have you assessed the chances of coming off the ventilator without a tracheostomy? What are their current arterial blood gas results, and what does it show? And does it show readiness for weaning? What are the alternatives if we wait another few days? What's your plan for weaning after the tracheostomy? And what happens if it fails? Can you show me the sedation and opiate plan and when you intend to reduce both? When you're asking these questions, you're not being difficult, you're being informed. You're showing that you understand the clinical picture, and that puts you in a position of strength. Let's look at the risk of tracheostomies that families aren't told. Well, every procedure has risks, but with tracheostomy, families often don't realize how serious some of them can be. Main risks include bleeding and infection at the tracheostomy site, damage to the trachea or also vocal cords, tracheomalacia or tracheal stenosis. A tracheal stenosis is the long-term narrowing of the airway. Tracheomalacia is a weakness of the trachea. Increased secretion management needs, i.e. frequent suctioning. Difficulty in weaning off the ventilator. Many patients may become ventilator or tracheostomy dependent, including the psychological dependency of it all. And in some cases, and that's for any country really, prolonged institutionalization, often leading in the US to LTAC or nursing home even. In other countries such as Australia or the UK, it can lead to long-term ICU stays. I've seen many cases where families in intensive care thought a tracheostomy was a step forward, but it actually delayed recovery and separated loved ones from home for months and sometimes even years. And that's also where intensive care at home comes in. So you can go to intensivecareathome.com to find more information there, but there is an alternative for a long-term stay in ICU, a genuine and legitimate alternative to a long-term stay in ICU, right? And you can find more information here at intensivecareathome.com, how we can help your loved one going home from ICU. Now let's look at step 4. What are the benefits and when it's the right time and reason? Now, to be balanced, tracheostomy can be life-saving. And like I said, right patient, right time, right why is appropriate in certain cases, especially if the patient has neurological injuries or spinal cord issues. The airway needs long-term protection, and they need prolonged ventilation support for recovery. It does then allow for better oral care, easier communication, once awake, and reduced or no sedation and opiate needs, but only if the plan and the timing are right. So, how can you question safely and collaboratively? So when you challenge the ICU's plan, tone is everything. What do I mean by that? You want to be calm, respectful, and also factual, of course. You could say something like, "We understand you are recommending a tracheostomy. We'd like to explore whether my loved one can try spontaneous breathing trials or weaning trials first." Could we have another day or two of assessment before making this decision? This approach shows that you're open-minded, but also that you're not going to be rushed. I also want to give you another hint here. I cannot tell you how many families we've helped over the years in ICU that are in ICU and are being told, the only option here is to withdraw treatment. Your loved one won't have any quality of life. They won't survive. So basically, they've been given the doom and gloom talk. Now, and I can't tell you how many families did not know about a tracheostomy as an option, because a tracheostomy can be a life-saving device for the right patient at the right time, right? So keep that in mind. Again, the biggest challenge for families in intensive care is that they don't know what they don't know. So what should you do if ICU is pushing you? And I'll give you some more examples about, tracheostomy versus withdrawal of treatment when we come to that. But I just need to drop that hint here that many families in ICU are not even told about a tracheostomy as an option. The ICU is deliberately withholding information so that they can stay in control of the narrative. So what should you do if ICU is being very pushy and is pushing you? If the ICU insists or says things like you need to make a decision now, that's a big red flag. You can always ask for a second opinion, which we can give you here at intensivecarehotline.com, where we talk to families in intensive care every day all around the world to review medical records, ventilator settings, ABGs, and provide you with a clinical strategy. You don't have to make a rush decision in the middle of the night on a weekend. You have time and you have rights. It's always interesting to me to hear ICU teams putting pressure on families and saying, you must make a decision, you have to make a decision today at 3 o'clock, whatever. Don't give in to that, especially if they haven't told you early on about a tracheostomy. Now, when it comes to tracheostomy, there are timelines that need to be adhered to for the safety of a patient, but you still have windows of opportunity. You also need to ensure that ICU teams have given you all the options that are available for you. And I see over and over again that they're not doing that. And this is where we come in to look at all options, right? And not just the options that ICU wants you to look at and wants you to believe in, right? So to summarize, a tracheostomy can be very helpful, but only when it's done for the right reasons, at the right time, and with a clear weaning plan. Or if a patient can't be weaned indefinitely, then with a plan to transition home to intensive care at home. Never agree to it blindly or under pressure. Ask questions, get data, and get help if you're unsure. Here at intensivecarehotline.com, we look at your loved one's ventilator settings, blood gases, and ICU notes, and I'll tell you exactly whether tracheostomy or not is the next logical step. Go to intensivecarehotline.com and book a call with me or my team, and we'll guide you one-to-one, step by step. So let's now look at how to avoid being pushed into a no reintubation or DNR pathway, right? So we talked about two options so far. One is extubation, potentially with support of BiPAP, CPAP, high flow nasal prongs, high flow nasal cannula, or ideally an extubation that doesn't need any further intervention, and the patient can be discharged from ICU hopefully pretty quickly after extubation. That would be the ideal scenario. Then we looked at tracheostomy as an option, and now we also know that ICU teams are often wanting to go in hard with, well, we should just extubate and not reintubate, a quote-unquote one-way extubation, which, by the way, is a euphemism for palliative care or end-of-life care, right? Then they will want to start the conversation around DNRs, which stands for do not resuscitate. Again, something you need to avoid at all costs, unless you have chosen that path, unless your loved one has chosen that path, right? But you should not agree to a one-way extubation with no reintubation as an option. That often also goes hand in hand with ICU saying, oh, then we'll send your loved one to a ward, to a floor, and they're not allowed to return back into ICU again. I've seen this over and over and over again, and you need to challenge that, right? First of all, you need to understand some key statistics in intensive care, depending on the research that you look at, but 70 to 90% of intensive care patients survive. So that means the odds are in your loved one's favor, right? The odds are in your loved one's favor. When ICU teams talk about end of life, they want to make it look like, your loved one's going to die no matter what, come hail, rain, or shine. And you have to question that, right? The ICU team has a duty of care for you as a family and for your loved one, right? And that's when you should get a second opinion, right? Especially at that crossroad. Should get a second opinion. Is your loved one going to make it? Is he not going to make it? Or is she not going to make it? What are the odds? Well, the odds are clearly in your favor because the statistics are proving that, right? But is your loved one really in that bracket that's likely to not survive? And why? Is your loved one in a real or a perceived end-of-life situation? What's the difference between a real and a perceived end-of-life situation? Well, I'm glad you've asked. A real end-of-life situation is a situation where no treatment, no surgery, no medication, no equipment, no nothing will save your loved one's life. They're going to die and death is imminent. Their organs are shutting down, their blood pressure is dropping fast, their heart rate is dropping fast. They could not survive without life support. The minute you reduce or stop life support, your loved one will be gone. That is, and only that is, a real end-of-life situation. Let's look at a perceived end-of-life situation. Well, a perceived end-of-life situation is a situation where your loved one is perceived to not survive, which means there is hope and there should be strategies used to give your loved one best care and treatment. And with best care and treatment, that's when chances of survival improve. Now, ICU doesn't want to talk about best care and treatment, right? And that brings me back to the example that I mentioned a minute ago. So a few months ago, I'll give you one real world example that you can actually understand what I mean by that. A few months ago, I was, we had a client here in Melbourne, actually, had a family member in ICU, 51-year-old man with a bleeding stroke. And ICU told the family from day one, your loved one's not going to survive, right? It's all hopeless. And we should just stop everything. We should just do a one-way extubation. He's got high intracranial pressures, right? And it's quote unquote in his best interest to die, a 51-year-old man, right? But it doesn't matter, even if someone is 91. Since when is it in the best interest for someone to die unless they have chosen to, right? So rhetoric really matters. Rhetoric really matters. Words matter. So, and then they asked me to come to one of those family meetings with the ICU team. And then I said to the family, well, instead of talking about a one-way extubation in case he's not waking up, have they told you about a tracheostomy? And the family said, no, they didn't know what a tracheostomy was. So again, the ICU team was deliberately withholding information to the family by not educating them. And it is so important, I can't stress this enough, that if you have a family member in intensive care, that you educate yourself about the whole landscape, right? That you do know about treatment options. Tracheostomy is a treatment option. It's a life-saving treatment option. Once again, for the right patient, at the right time, and for the right why. So if ICU teams, and it's not a unique scenario, right? We consulted many other families in intensive care over the years where ICU teams are not telling families about treatment options. You know, they just want to create the negative and doom and gloom narrative about, oh, well, your loved one won't survive. If they will survive, they won't have any quote unquote quality of life. So it's quote unquote in their best interest to die. It's a narrative you need to challenge, right? And then they start talking about DNR and NFR. DNR stands for do not resuscitate. NFR stands for not for resuscitation. It's, you know, the terms are interchangeable. It means the same. It also means that the minute they've, you know, your loved one is a DNR or an NFR, that ICU teams are basically giving up and your loved one will not get best care and treatment. So if there are any questions, please type them into the chat pad. If there are no other questions, you know, we'll shift gears now and talk about intensive care at home, because that can also be a life-saving alternative if your loved one does have a tracheostomy or does need a tracheostomy, right, and needs it long-term. It's either tracheostomy long-term, needs ventilation with a tracheostomy long-term, but also might need ventilation long-term with BiPAP or with CPAP without a ventilation. So in those situations, intensive care at home is often the next step. So if a tracheostomy has been done, what happens next? Most families are told the only options are long-term ICU, end of life, right? Or in the US, families are told that LTAC rehabs or nursing homes are next. But there is a better way, of course, with bringing intensive care at home safely. That's where intensive care at home comes in, where we provide ICU level care in the comfort of your own home with 24/7 intensive care nurses, the right equipment, the right teams, and the right mindset. And the right mindset is so critical. So how does intensive care at home work? Well, the eligibility for intensive care at home is usually, you know, if someone is meant to be in ICU long term with a tracheostomy plus minus ventilation or BiPAP CPAP ventilation without a tracheostomy, but also when clients have a tracheostomy without ventilation. It's a 24/7 critical care nurse model. We are fully third-party accredited, and you know, we are a legitimate and genuine alternative to a long-term stay in intensive care. So with this transition process from ICU to home, right? It usually starts with either the family or the patient or the ICU identifying that this is a good model to move to and that it's a win-win situation. What's the win-win situation? The win-win situation is that an ICU bed costs $5,000 to $6,000 per bed day. A family in intensive care and a patient in intensive care who's institutionalized does have no quality of life, right? An ICU and a hospital desperately needs ICU beds. A family and a patient desperately want to go home because they're traumatized from their ICU and hospital stay, right? So then with providing intensive care at home, it's a win-win situation, right? I can give you so many success stories with our clients for intensive care at home, where our clients are at home now instead of long-term intensive care, where real clients have real quality of life at home instead of intensive care, with a 24/7 critical care nurse or ICU nurse model. Something that I'm extremely proud of is that, pretty much all of our clients have community access. There might be one or two can't, but pretty much all of our clients, ventilated, tracheostomy, they all have community access. So what that means is they're out in the community every single day of the week. They're living life, right? And the good news is it comes at a much lower cost. We're slashing the cost of an ICU bed by 50% approximately. And we're freeing up the most sought after bed in a hospital, which is the ICU bed. But we're also providing quality of life for patients and for families, and you cannot put a monetary term on that. Do you know what one of the biggest fear for our intensive care home clients is? One of the biggest fears for our intensive care home clients is to return back to hospital or to ICU. That's one of the biggest fears. And part of our promise to our clients is that clients can stay at home predictably, right? So we've helped countless families get their loved ones out of ICU safely in Australia. All right. Imagine your loved one at home, surrounded by family with proper ICU care, not isolated in ICU or in a hospital ward. That's another danger that some hospitals, and that's mainly now in Australia or the UK, want to send their loved ones to a ward, to a hospital ward on a ventilator with a tracheostomy while they still need ICU care. So how do you start the process going home? Well, you start the process going home by, number one, identifying that you've had enough, that you do not see any further progress in ICU, and that it's bogging you down, that it's costing you your sanity. It's probably costing your loved one's sanity in intensive care. That's number one. You're identifying that you cannot continue like that. Right? Then you reach out to us here at intensivecareathome.com, and we help you with getting the approval, getting the funding, writing the reports, whatever, looking at the medical records, because this cannot be done with just any registered nurse, or let alone support workers. This needs to be done with highly skilled and highly qualified ICU nurses 24/7. Another important aspect of this that I haven't mentioned, but I think is so important, is the dignity of your loved one, the dignity for you as a family, day and night rhythm, a proper night's sleep, not having a disturbed day and night rhythm as so many patients in ICU have, right? If you've ever spent a night in an ICU, maybe as a family member, or God forbid, even as a patient, you would know that your sleep is being disrupted, lights are being switched on, people are coming in talking. It's terrible, right? Imagine at home, you're in your own room, family is present. You can let our nurses know how you want to run your day, your night. You are in control, right? It's a win-win situation for everyone, right? Another thing that I forgot to mention, I should have mentioned that in the beginning, when it comes to transitioning home, especially if you or your family member qualifies for NDIS, we're also providing level 2 and level 3 NDIS support coordination. We're also providing TAC and WorkSafe case management, right? Because that's often what leads to funding. So if you want to find out whether your loved one can go home from intensive care with Intensive Care at Home, go to intensivecareathome.com and book a call with me today. The worst thing you can do is wait. Hospitals won't tell you these options even exist. They want to stay in control of the narrative. They often also want to stay in control who lives and dies, right? I've just given you this example of this 51-year-old man with the bleeding stroke, the hemorrhagic stroke a few months ago. Well, if the family hadn't questioned, they would have gone ahead and would have extubated him and he would have passed away. No returns from that. Now, when I started advocating for tracheostomy and they then had a tracheostomy, imagine that he was extubated, he had the tracheostomy removed a few weeks later. And he's now on the mend. I am in contact with the client. It is mind-blowing. It is mind-blowing. It boggles my mind how doctors and nurses in intensive care cannot advocate for their own patients, right? If we hadn't done that, if the family hadn't found us, their loved one would have died. It's unbelievable, So let's wrap up with your questions. If you have any questions, of course, type them into the chat pad, please. Today, we covered how to make informed tracheostomy and ventilator decisions in ICU, and how you can make them confidently, and how intensive care at home can be the next step to freedom, dignity, and quality of life for your loved one. Don't forget to like this video, subscribe to my YouTube channel, click the notification bell, and share it with anyone who will benefit from this video, i.e. who has a loved one in intensive care. And remember, you're not powerless. You have options. You have rights. And we're here to help you every step of the way. Every step of the way. Right? You're not alone. You are not alone. We have a team of highly skilled, highly motivated critical care nurses that want to grab you by the hand and handhold you through this step by step. We know how overwhelming it is. We know what dark places families in intensive care and patients in intensive care can drift to. Let me know that there is help, there is hope, and there is light. Do not give up. I know that you're in a dark place, but we're here to help you. And we would love to talk to you and show you that there is a life beyond ICU. Do not let negativity bog you down. Do not let negativity bog you down. Okay? So, I also want to make a quick comment about some comments that sometimes people make on my YouTube channel. I just want to address them. Sometimes people comment that, we're charging money here for our advice. Well, that is true if you engage with me one-on-one, not for intensive care at home, but for anything intensive care hotline related, I do charge a fee. And I make 7 videos a week as free advice. So for someone to say that you get charged is not accurate. There's so much free information out there. And believe me, even making these videos is also costing money. I have a team and thank you to my team here, right, that helps me to make these videos, right? So we are funding upfront that people can have free advice. If people want to talk to me directly, they can do so by booking a free 15-minute consultation for intensive care hotline. If you need intensive care at home, you contact me anyway. And then I offer paid consulting and advocacy for intensivecarehotline.com, right? But if you have questions when you have a family member in intensive care, you can always come to this live stream and ask me questions here. I won't charge here. But just keep in mind that we have to keep this content produced, right? That there's a lot of time and effort that goes into this, right? That cannot be underestimated. So there's by now over 1,000 videos out there on my YouTube channel about advice for families in intensive care. So you can consume that content. Your answers are in those videos, I can assure you. If you spend enough time searching my videos, you will find the answers. Talking to me directly is, of course, the shortcut. Now, I want to thank everyone for watching this video, for joining us here. I hope that you have a good week and the rest of the weekend, and I'll talk to you again next week. Take care.